Dear friends, dear colleague, welcome back to the Mangano Digital Academy and welcome back to the essential of digital dentistry. In this last videos of the make phase, the last phase, the production phase, we talk about non-conventional solution in digital dentistry, and this is one of the cases. We are talking about root analogues in this short lecture, in this short presentation. We are all aware of what digital dentistry is. Digital dentistry is divided in 4 different and basic steps. The scan phase is for data acquisition. From the real we go to virtual, so we acquire a set of data of our patient through combing computer tomography, intraoral desktop face scanner, digital condylography. All this data can be combined together manually, superimposed, or by means of artificial intelligence software combined and fused in order to obtain the virtual patient. These data they are sent to the laboratory where they are elaborated, and this is the phase of the plan with the computer assisted design software. For example, computer assisted design software for surgery, for prosto, for orthodontics. After we have completed this phase, we go through the making of, so the production, and we shift from virtual to real again, thanks to computer assisted manufacturing software and units like milling unit, 3D printer, and SLS, SLM unit. In this lecture, we talk about these units, SLS and SLM units, for making root analog in titanium. And then we go to the clinical application. What about root analog? Root analog implants is something that come from the past, because the first implants during the Roman Empire were basically root analog in ceramics. But we don't need to go so far. We can talk about what we find in the literature recently in the last 10 years. If we search with these keywords in the PubMed, custom-made root and analog, we found a few studies. I have to say most of them are case report on the technique that is additive manufacturing with titanium or titanium alloys. There is something also with zirconia, particularly milled zirconia, but obviously the potential for printing the zirconia root analog is even higher. But let's go through this review of the literature with the historical development of root analog implants. In this basically published paper in 2019, we find basically all the different applications with the different material, and it's a nice, very nice review on the topic, and I suggest you, if you are interested in root analog, to look at it, because the most of the cases from 1969 are enlisted here with the different material and with the different combination and solution by different authors. And here in these slides we find that the most recent publication, some of these publications are from our group. We published it together with Professor Figliuzzi from the University of Catanzaro. We published it together different specialists like Dr. Cirotti, and different cases, I have to say. In total we performed only 15 cases, but all these cases were on patients, so in vivo studies with root analog in titanium or titanium alloy, so 3D printed root analog. Obviously there are several, of course, other authors, and one of the material used by, for example, Wolfgang Pirker and his colleague is zirconia. Probably zirconia is even better as a material for this specific application, but we will focus only in this case on titanium, because our experience is with titanium. This is basically how it works, and we started to work with this principle around 10 years ago, 12 years ago, in 2010. So combing computer tomography scan, then we have a phase of computer assisted design in which there is the 3D reconstruction of the bone, the segmentation of the tooth. As you can imagine now, it's even faster and easier with artificial intelligence, but in the past it was manual, so the segmentation was manual. It was quite tricky, but an operator dependent, but anyway it worked. Then we have to isolate the standard tessellation language file of the virtual root. We need to design an abutment over it, an integral abutment with additional features, for example, vestibular slides for the protection of the buccal bone in order to avoid any pressure on the buccal bone, platinum switching if we want to do it, for a cemented restoration. And then we move to the computer-aided manufacturing by means of selective laser sintering, selective laser melting. and then we are ready for the clinical application. So this is the case. We used the EOS machine to fabricate these implants, and it worked quite well. We use a different percentage increment of dimensionally of the same object, but at the end we use at all time the 0% implant, the 0% increment. This is the first case probably ever done by our group, by Professor Figliuzzi from the University of Catanzaro, and it is very beautiful, as you can see, very elegant. Before to physically extract the tooth, we perform a segmentation of the bone, a segmentation of the root, and a virtual extraction of the root. This root then is treated with and added with an integral abutment, as we can see in specific software like Rhinoceros or other software with the different features, and then we can fabricate the implant, and after the extraction with a little percussion hammer it's very easy to place the implant. So no preparation at all, it's very minimally invasive, I would say. Obviously the extraction must be totally conservative. In this case, Professor Figliuzzi, this case was performed by Professor Figliuzzi, was very delicate because you need to care about the periodontium very much, you need to care about the existing structure, because if the extraction is traumatic, then the implant will not fit perfectly. But if the extraction is totally atraumatic, like in this case, then we will have a perfect congruence of the implant within the post-extraction socket. And in this case, Professor Figliuzzi performed an immediate loading, even if it's not functional, and after 3 weeks we can see a perfect integration with the provisional in situ. In this case we are talking about a cemented restoration. It is the way it looks after 1 year with the restoration, and the publication was made in 2012 basically, and this implant now is in position since many years. We are talking about 8 or 9 years of follow-up, and it works perfectly. Here we have the follow-up after 2 years and after 4 years, and look how natural looking it is. Look how the level of bones are maintained over the platform switching. The design of the implant was perfect. In this case the restoration was perfect, and everything is working very well. And Professor Figliuzzi is going to publish the 7 or 8 or 9 year follow-up very soon of this case. Here once again 4 years after, look at the perfect soft tissue integration, look at the aesthetic integration of the implant, everything worked very well. And these are cases a little bit more tricky because not only monoradicular teeth can be done with this technique, also the first premolar, for example, in the maxilla. Look at how funny it is, the radiograph with the tooth that has 2 roots. It's really interesting what we can do with this technology, because probably the primary stability is not the one we expect, but anyway there's an excellent integration because of the power of the surface, because the surface in this case is a porous surface, and this surface enhances bone integration. At the same time, the soft tissues seem to like this porous surface. There is an attachment. Of course, there is a lot of discussion in the last years about surfaces and perimplantitis and these things, but I have to say in these very few cases made, we didn't have so big trouble. Only one of the implants at the end, after several years, one of the 15 implants placed had been lost for perimplantitis after many years. So I have to say that globally it worked, even if we have a very few cases, and of course there's a need for more studies, but this is a very particular solution, and obviously sometimes it's much easier to place a standard implant and definitely less expensive. And this is the control. These cases were made by Dr. Bruno Cirotti, and we published it together in Lasers in Medical Science in 2012. In that period we were trying to experiment different kind of these implants, and they worked well, quite well clinically, as you can see. But after all, if you watch in the perspective, yes, probably we don't have sufficient evidence to support the concept of custom-made laser sinter root analog in titanium now, Probably in zirconia it is more interesting in perspective, particularly if we think about 3D printed zirconia, because we have all the tools now to do it. We can use artificial intelligence for the segmentation. We can use 3D printing of ceramic for the fabrication of the implants, for example, with the litho machine, the Serafab S65. So we have potential. We have all the machine that we didn't have 10 years ago. 10 years ago it was not possible, but now it is really possible to revise all this concept and try to adapt this concept to zirconia, because probably titanium is not the way to go. The literature says that zirconia is definitely better. We need to shift our attention to the zirconia, to the new material, to the 3D printing of zirconia as well. Thank you very much for your kind attention.